Have you heard of the drug Midazolam? Midazolam was and is used as part of what is called end-of-life care. Precisely how and why it was prescribed during the past 3 years has preoccupied the minds of many people. Those whose loved ones were given Midazolam, in care homes especially, want to know more about how and why the decision was taken to prescribe that drug. Joining me now to air the topic is Reclaim UK MP Andrew Bridgen, and also Emma, who questions the part played by Midazolam in her dad's death. Thank you both for joining me.
Thank you.
Andrew, if I can come to you first of all, what is it that you are being asked about Midazolam, and by whom?
Well, I have concerns, Neil. I'm one of the MPs who voted in 2014 to get rid of the Liverpool care pathway as being harmful and unsuitable. And in April 2020, Matt Hancock and the NHS authorised NG, NICE Guideline 163, which since then, relatives who've lost their parents and loved ones have come to me and said they believe those guidelines, the prescription of midazolam and morphine, a respiratory suppressant, to people who were already suffering depressed respiration, that it accelerated or caused their death. I held an event in June where 70 bereaved relatives came, and a lot of them had a chance to give very harrowing accounts of their experiences of their relatives' end of life in hospital. And the government don't seem to want to talk about it. I wrote to the government reasonably, I thought, some reasonable questions. One of them was how many elderly, vulnerable people were moved out of hospital into care homes to make way for the expected first wave of COVID patients in early 2020, and how many of those had sadly died within 7 days, 14 days, 28 days, 56 days, etc., of A, COVID-19, B, other causes. And the government wrote back and said they don't hold that data. So they're telling me they have no idea who they moved out of hospital and what happened to them.
Which seems extraordinary.
Very extraordinary. And Emma's here to tell her story about her father. And unfortunately, I've heard far too many of these stories over the last 12 months.
Emma, if I can come to you, what is the story that you would like to be more widely known about your dad?
Well, first of all, Neil, I'd like to thank you so much for taking this opportunity to have me on. I'm here representing all the people who haven't had a voice so far, and this is the story about my dad. I've written it in note form because it's obviously a very emotional subject for me. He was an extremely fit 83-year-old, 84 when he died. He loved walking. He lived for life. He did sport his entire life. The year beforehand, we went to the Lake District and we climbed Scarfell, which took us 7 hours. That Christmas time, 2019, he outdanced everybody at the community centre. Everybody was just loving it. He just had such a fantastic afternoon. When it came to looking for a care home in the January, it was really important to us that we sourced a home that could cater for his activities so that he could remain in his walking groups, and they assured us that he could. He wanted to remain active and keep on about his daily routines. During his time there, which was 10 months, he inexplicably deteriorated. By the 2nd of December 2020, I went to see him and I was absolutely heartbroken and shocked. I'd seen him 3 times that year, and this time, this man who'd been walking, could outwalk anybody, he was wheeled out in a wheelchair. He was absolutely slumped down with his head just fallen. And he was wheeled towards me and I was sat there, and he lifted his head up, which was really difficult, and he saw me, tried to lift his arms, and the assistant manager said, "No, Jack, sit down. You know you're not allowed to hug anybody," and wheeled him straight past me. And I was in absolute devastation at that point. And this to me was, it took about 10 months for this to happen. And to me, he looked heavily sedated. And I made it clear the next day when I rang up, I made a complaint. And I said, "What have you done to him? He looks heavily sedated." I was expecting a call back, but I didn't get a call back from anybody until his main carer actually gave me a call, and I wasn't expecting her. And I got on really well with this particular lady, and I really felt that she was trying to tell me something, because out of the blue she said, "Emma, I really hate to say this, but your dad's very, very ill and he needs to be in hospital, and I'm going to be really honest with you, I don't think he's going to make Christmas." Now, this was this was the 4th of December. And I didn't know how to take that bit of news. I mean, it's not the sort of thing that you take lightly, and I don't think it's the sort of thing that she would have said lightly over the telephone if she didn't knew it to be true. She also said it's been a pleasure looking after him and that she'll miss him. He got transferred to a hospital the following day, on the 5th of December, but this wasn't even the hospital that he's used to be going to. It was a completely different hospital, 27 miles away. And the pathway that I'm going to tell you about a little bit later, this is where that pathway was created. The following week, they wouldn't let me in at all. Despite all my efforts, I kept getting told, no, he's not end of life, he's not dying. But I kept thinking that his carer wouldn't have just said that, you know. They wouldn't let me come in. And then they kept using this word agitated. He's in for agitation. And I'm like, why do you get sent to hospital with agitation? It just didn't make sense. And they stuck to it over and over. Finally, after about a week of trying to get into with my dad, I spoke to a sympathetic nurse on, by now, this was the 11th of December, who agreed that I could finally come in and see my dad. He said, I think it will be good for you and I think it will be good for him. I was absolutely shocked when I saw him, even worse than before.
At what point do you think Midazolam was playing a part in what was happening with your dad?
I didn't know at that point anything. His speech had completely gone. His mouth was covered in blood, his jaw was just rolling around. He had bumps and scratches all over the place where he'd had lots of falls, and that's specific with a lot of those types of medications because they affect your central nervous system. So he'd had a lot of falls, so he had bumps and scratches, a bit of a broken nose, black eyes. He was in a terrible state, and also 10 kilograms lighter as well. And that would have had a huge effect on the medications that they gave him in the next couple of days.
Can I just pause you there while I bring in the doctor? Mm-hmm. You know, because I think it's appropriate that we bring in Dr. Malcolm Kendrick, GP. You know, you're listening to this, Dr. Kendrick. Can I just segue, bring in your contribution at this point? How were elderly people in care homes being treated? You know, were GPs readily admitted during the time of lockdown to see patients face to face?
Well, a lot of doctors didn't go in to see people face to face. I worked in a number of care homes and also in working with the elderly, and saw approximately 36 of people that I was involved in did die of what was probably COVID. But yes, quite often, and during this situation, a lot of people were prescribed things without necessarily being seen by the GP. So that would be the case, yeah.
So it wasn't necessarily the case that, as one might expect in the case of the care of a loved one, that a GP was intrinsic to that process, that treatment was being administered by people who weren't general practitioners.
Well, it would normally. Well, saying they didn't go in, they would have been communicated with, sometimes over Zoom calls or whatever. So there would have been a decision made by a doctor somewhere that the patient was approaching end of life, and that therefore, if they could put them onto what are called the end of life medications, that would be a medical decision. Sorry,
it must surely take a great deal of wisdom, you know, to be looking at an elderly patient who let's say has a respiratory ailment that's making it hard for that person to breathe. How would a decision be made about whether or not to treat that person and keep them alive, or on the contrary, to prescribe a combination of drugs, including Midazolam, which suppress breathing?
Yeah, well, I mean, these are difficult decisions. They are very tricky things, obviously, because you are at a stage where you're saying to relatives that we believe that, you know, your loved one is actually getting worse, is not going to recover, and therefore we need to try and make them as comfortable as possible. You wouldn't necessarily be put on Midazolam. It would be what they call a drug. If someone did become agitated, terribly agitated, they would be given Midazolam. That was the case before COVID. It's still the case. I mean, I still see elderly people who reach a point where you think this person is at, if you like, within days of probably dying, and we withdraw kind of the standard treatments. But, you know, the Midazolam is is widely, it's still widely used. I mean, it is but it's always used. I mean, if someone was being given it months and months before their death, that, you know, obviously I can't comment because I don't know the case, but you would be thinking that is probably premature if that was happening. You know, and as Andrew Bridgen said, well, the end of life, the Liverpool care pathway was got rid of, but the end of life pathway, which I don't like calling it a pathway because it does sound a bit like you're on a path and it's a conveyor belt, and it's almost some people did see it that way, unfortunately. The basic treatments that are given, if appropriate, are really just to try and make people as comfortable as possible.